let's go ahead and get started. I'd like to begin, though, by introducing our geriatric fellow here at Sparrow this year, Christy Beckholt, and I just want her to give you a little introduction on why she chose geriatrics and a little bit about the fellowship, and then if you have any questions, you can ask her.
Hello. Whoa. So I'm Kirsty, and I'm one of the two. We have two geriatric fellows, and Mega is the other one that's back in the corner. And I went into geriatrics because I think they're a really difficult patient, and when you're in family practice, you know, you see the geriatric, or you see like an 85-year-old with multiple medications, and it just gets a little overwhelming. And they're harder, but they're really sweet, they're awesome, and they're fun to take care of, and so that's why I wanted to go into it. The fellowship helps you a lot with time management with these patients and how to go through it without getting behind. They don't take an hour. You can get to see a patient in a half hour and go through all their medications and ask how their function is and talk to the patient and the family. The fellowship is set up, it's a year, as everyone's been saying, you heard. We do a few months at a nursing home. The one here in Lansing we're mainly at is at the Ingham County Care Medical Facility. We have a senior health center where we only see geriatric patients. So they're 65 and older, and we spend a lot of time there. We do rotations in geropsych unit. We do a month in hospice. We do PM&R. We have 2 electives, so like you can pick those within realm of in the geriatric area. Like one of mine will be OMM for a month, and another one I'm doing podiatry. And then we go to a memory disorder clinic up in Grand Rapids, where there's a physician that specifically just sees memory disorders, which is really, really interesting. And you learn a ton about different dementias and the different types and how to diagnose them. And you start to feel really comfortable diagnosing Alzheimer's versus vascular versus the Lewy bodies. And it just really helps get a better understanding and making you feel comfortable and making that diagnosis to a family. Because, you know, sometimes that's a really hard thing to tell someone. Are there any questions? I'm assuming that means no. Any questions? Okay, thanks.
Okay, thanks, Christy. And we can give you her email in case a question comes up and wakes you up in the middle of the night. Yeah. And I just have to say, and I know that a lot of you I had contact with when you were students, but I often say that, you know, geriatrics chose me. I didn't choose geriatrics. That was not what I intended to get into. And that was 35 years ago. So, you know, and it's been a good career. And one reason I chose it, or that it chose me, and it seemed like a good fit, was in family medicine, you get to see a variety of types of patients, and that's what I liked and why I chose family medicine. But repeatedly, when you're seeing those patients that you just can't get better, that are younger, especially like workman's compensation patients, that the only way they get better is to get the green poultice, that gets to be very depressing. At least to me it was. And when I saw my older adult patients, they were honest, they had a long history to share with me, and I enjoyed seeing them and interacting with their family. And I still enjoy doing that today. So remember, when you're seeing that workman's comp patient that may not be the most legit, maybe geriatrics will be the field for you. Okay? Okay. Now, today I want to just have you feel comfortable about what we're going to talk about here today. And that's practicing our skill. The one thing that being an osteopathic physician does is it really gives us another focus of treatment on especially our older adult patients, where we don't have to rely on pulling out our prescription pad and writing another narcotic. And, you know, we're special because of that. No one else can do that. And your older adult patients will really value that kind of intervention. And I have colleagues that only do that. I have a friend down in Fort Lauderdale who practices, his practice is called non-surgical orthopedics. And this is all he does. He has family practice too, but his main focus of treatment is osteopathic medicine. So I want to show you just some of the general precepts to remember, because your older adult patients aren't going to break. Granted, we're not usually doing high velocity techniques, but you know, I just think it's a good way to give you an introduction, and as you're going through your residency, you can start to practice some of these skills. I know, you know, those of you that went to MSU here, you know, you've had an excellent osteopathic education. I went to Chicago. I got a little bit different education with their osteopathic techniques, but we all kind of, you know, meld together and can learn from each other. Just to, you know, give you some of the main categories of somatic dysfunction, we're going to look at the things that you always look at, the TART, the tissue texture changes, asymmetry of, especially of movement, restrictions of movement, and tenderness. And your treatment modality is based on your assessment. And the assessment is one thing that I want you to just become comfortable with and just look at kind of like the simple things that the patient does. Even when they walk into your exam room, you know, that's going to give you a lot of information on just what your patient can do. Especially if they're already sitting on the exam table, you don't know how they got there. I mean, were they dragged in there? You know, how did they get up on that exam table? So I like to do motion testing and first have the patient actively do whatever they can do. So if they're telling you they have a, you know, a sore back, or they can't move their arm, or they can't move their leg, well, see what they can do before you go and grab an arm or leg and start moving them around. We also, as I mentioned, as geriatricians, want to see some kind of functional assessment. So I like to do a timed up and go test. If you really want to do an in-depth test, you can do a POMA, performance-oriented mobility assessment. It takes a little bit longer. Look at specific anatomic regions, as I mentioned. And then once you see what the patient can do or what their limitations are, then you can assess for passive range of motion. Look at the tissue texture changes, skin temperature. Is it warm, which would indicate an acute injury? Is it cold, maybe indicating vasoconstriction? What's the skin and fascia tone like? You know, acute injury is going to be edematous or spongy. Chronic, it's going to be more stiff and fibrotic. Check for symmetry of the patient, just looking at them standing or sitting, and look at the whole body, the gait and balance of the patient. Can they maintain an erect posture without falling over? It amazes me how we got patients that come in with a complaint of dizziness or falls, and we never question them. In fact, there's been many studies that have looked at, you know, allopathic and osteopathic physicians who see a patient that had a complaint of a fall, and then the physician never questioned them about that. never had them walk, never had them do any kind of maneuvers to check their balance. and you're just missing the boat in that patient. Obviously, look at the spinal curves, this posture, the bone condition. Observe and compare regions, similar regions, paired muscle masses, leg length discrepancy, and paired joints. Now, tenderness is something that all of us kind of focus on, right? A patient comes in and says, I got pain in my shoulder or pain in my back. Well, we look at that. But the pain or tenderness may be the least important point for us as what we're going to develop our treatment plan on. So, is that pain from a referred pain source, a muscle, bone, or a visceral organ? So, I know a lot of you have a lot of techniques that you've been taught in medical school and that you're practicing now. In older adults, my focus is more on soft tissue techniques, stretching or mild traction, linear or longitudinal stretch, sometimes a lateral stretch, sometimes deep pressure, myofascial release. Those are more the techniques I'm looking at. I'm not really doing, high velocity techniques. So our focus is to try, when we see that a patient can't move, actively, passively, our focus is to try mobilization. So with slow, gentle, controlled movement and osteopathic techniques, hopefully we can increase that patient's mobility and reduce their pain that they have. I'll never forget when I was in practice in Florida and I saw patients at a life care facility, and this elderly woman comes in to see me first time, and she had severe degenerative arthritis of her knees. And she's walking into the exam room like this with the knees touching. So I'm already creating an opinion, I got to give her something for her knees. So I ask her, what brings you in to see me today? And she says, well, I want to see what your brand of medicine can do for me. So I'm thinking, okay, I'll refer her to an orthopedic surgeon, have a knee replacement. Well, then she tells me she was a Christian Scientist, so she wouldn't consider surgery, and she wouldn't take any medication. And then I said, okay, well, we can probably, try something else on your knees. Well, then she said, my knees aren't hurting me. It's my back. Well, when I examined her back, she had a compensatory scoliotic curve, a lot of perivertebral muscle reactivity, a lot of restriction of movement. And I said, okay, well, here's what I think we can do. So I came up with a treatment plan to do some osteopathic treatments to her thoracic and lumbar spine. Saw her weekly, also gave her some exercises, and within a month she had returned to driving, going out to lunch with her friends, and driving to the beauty shop. And then I was able to back off and only see her like maybe every 6 to 8 weeks. And all of that was, just with my hands. She wouldn't take a narcotic. She wouldn't actually even take Tylenol. So, here's something that we could offer her. And just think of it. If it wasn't for the osteopathic intervention, what could she do? What would she take? Mainly because of her religion. That was, focusing her direction of treatment. So that's what I want you to kind of remember today. And the first time you see a patient like that, you'll remember that too. So our soft tissue immobilization techniques are to enhance motion, mechanically stretch the skin, fascia, and muscle, relieve hypertonicity and spasm, we actually try to focus on getting that muscle to fatigue so we can, when it is in spasm, so we can increase the range of motion. Look at all the anatomical regions, cervical, thoracic, and lumbar. And often our treatments are not just when the patient is supine on a table. Sometimes it's better if they're actually sitting in a chair if we're trying to do some of our techniques. Also, shoulder, hip, knee, and ribs. So this is a patient that I had in the nursing home that Dr. Beckhold talked about. He's since passed away, but the funny thing is he was actually admitted there on hospice and because of heart failure. And we got him as a geriatrician and in palliative care, we got him to the point where he graduated from hospice. And he lived at the nursing home for a good 3 years after. But he was a good example of what you can do for some of the osteopathic treatments. So the first thing you want to do is to really just look at the range of motion. So, I just ask the patient, turn your head to the right, turn your head to the left, just see how far they can move. Just seeing what their active range of motion is. So he's a little more restricted rotating right. And you can even just do treatments, with the patient seated. Obviously, we can also do it with the patient supine. But, cradling the cervical spine with your fingers on the paravertebral muscles and just providing, lateral stretch. Usually we try to hold that impulse for maybe 60 to 90 seconds. So you'll feel the muscle fatigue and then come back, reposition, and reapply the pressure. So first I'll do, have the patient do the active testing, then I'll do motion testing passively myself and see where the limitation of motion is. Once you find where that barrier is, that's when you introduce your pressure or your impulse in that area and hold it for 60 to 90 seconds. Now you can also, on some patients, to use muscle energy is another possibility. When you reach the barrier and just have the patient gently resist your movement. You have to at least know what their bone density status is because, they potentially can exert quite a bit of pressure just by their resistance with muscle energy. But, much the same as what you would do with a patient supine, and I have a picture of that later here too. So, I think most of you are used to doing a cervical or linear traction. That's very helpful in a patient that has cervical and upper thoracic restriction of mobility. So that's just straight linear traction. You can also, if the patient has more limitation of rotation, you can introduce resistance on rotation right or rotation left. every once in a while I always have to catch myself because when I went to school in Chicago, we were taught a lot of high velocity techniques, and it's like, oh, I wish I could just do that here. But you position the patient till you reach the barrier and exert a little, just a continued pressure in that direction, but hold it for 60 to 90 seconds until you feel the muscle fatigue. Then reposition the patient in that same direction. You can do that maybe about 2 or 3 times, and then gradually you'll be able to increase that patient's range of motion. Same thing with thoracic motion testing. Palpating the thoracic paravertebral muscles. A little delay in the mouse here. And I like to use my elbow in enhancing the mobility of checking the mobility of the patient. I'm not really laying on his shoulder or anything, but it just helps give me a little more ease in moving the patient. And the older I get, the less ease I have in moving my patient. So it may be a little uncomfortable for you at first, but with practice, you're kind of moving your whole upper body as one and getting the rotation in the patient. So as I see where that restriction of motion is, I'm checking rotation right, then I'll get on the other side, check rotation left, see where the restriction of motion is, and that's where I'm going to focus my treatment. So my motion testing is my same corrective intervention. Okay? And that's what's so simple, and it took me a long time to figure that out in the older adult patient. And you think, I'm not doing anything all that complicated. And that's why I want you to leave here today thinking it's not complicated. But your patients really receive benefit from it. They'll go pay a massage therapist, $100. And they're not doing half of what you guys can do. Okay? This is your procedure as a family doc. You don't have to buy any supplies. You don't have to get any needles. You don't have to even take out your prescription pad. All you have to do is explain to the patient what you're going to be doing, and that's your treatment. And here he's sitting in a wheelchair. In your office, you can have him sit on I like a little low bench and have him actually sit on the bench. Sometimes you can have him straddle the bench. But here I'm holding him in that position until the muscles fatigue, and then gradually get the increased range of motion. Same thing, and I'm sure you've seen some of these techniques, so I'm going to go on, but same thing with the patient on their side, thoracic and lumbar. You can check shoulder motion testing. Actually, this one. I just feel like I'm on every which way but loose on this. If you ever saw that movie. But if you look, you can see his left shoulder, he's not raising, his arm isn't as high. So just by his active range of motion, I have an area where I can focus on, and also treating the thoracics that can benefit him. And then shoulder elevation treatment, or in patients that have restricted mobility in their shoulder, stabilize the shoulder with one hand, and then try to not force but encourage movement where it's restricted. So all your patients that have degenerative arthritis of the shoulder or rotator cuff injury of the shoulder may not be a surgical candidate or may not want surgery. So what are you going to do? Just give them narcotics? Our job is to help mobilize that joint to the best of our ability, and we can, usually help accomplish that. So in this patient, I would stabilize the shoulder with my right hand, and then go through abduction techniques on the arm and elbow there to enhance movement in the shoulder. And same thing there. Motion testing, muscle strength testing in the leg and lower extremities. I'm sure you're all familiar with doing that. Again, if there's arthritis in the hip, we can, and the knee, we can, encourage the same kind of mobility with resistance to your range of motion. Rib assessment and respiratory excursion. Again, there have been some studies done, and even over at McLaren Lansing, they're doing techniques like this with patients after cardiac surgery. So you check rib mobility, check for any restriction of inspiration and expiration, and then again, our treatment is the same thing, but to our resistance. So have them take a deep breath and hold it with the resistance of our hands to their movement. And rib raising techniques, I'm sure you've seen those too. And here I'm positioning my hands, and then have the patient come back over on your hands, and then you're actually using your fingers of your hands flexing to raise the rib. Okay? And that can be done on patients that are, in the hospital. Now, there are a number of different techniques that you can use for abdominal treatment, especially in your patients that may have chronic constipation. And, some of them are called just transabdominal stimulation. There are all kinds of ways you can do it. Some are like with rhythmic stimulation of the abdomen, starting maybe in the sigmoid, going up the descending to transverse colon to to the ascending colon. But it really doesn't matter, I don't think, how you accomplish it. All I can tell you is this patient enjoyed this treatment. So this is more of, I guess, more like a lymphatic pump technique. Now you have to know your patient, I guess, to do this. But you can also, similarly, you can start at the sigmoid and come back, actually move around and come up to the transverse colon and then the ascending colon. But, often, you got to remember, a lot of our patients like this age and nursing home, hospital are immobile most of the time. So, they don't get much movement. They may be on fluid restriction. So any movement of the abdominal contents can help. You can also use the Dalrymple pedal pump, to do kind of the same thing, hold them by the feet and just kind of give them a rhythmic motion back and forth, and you'll get the same thing. And also with the upper lymphatics, and position your hands like you would with, like riding a bicycle handle, and just find out where the restriction of motion is and get a rhythmic motion there to stimulate the lymphatics. And positioning limitations, I don't look at it as a limitation. That may just be a guide for you on how you can treat the patient. So if they're bedbound, well, that's where you got to do the treatment. Don't worry about getting them up, sitting them up in a chair, and whether they're ambulatory or not. So you got to go to where the patient is. Contraindications, obviously, if there's any fractures, you don't want to be, moving them around that way. Osteoporosis, be aware of it. I don't think I use any high velocity techniques when I'm treating my older adults. And the other thing is, even in patients that are in hospice, it can be another adjunct in your treatment. In fact, that's one thing that we're looking at, and we'll probably be starting a student clinic at one of the local hospice residences. So, use the tools that you've been trained with. It'll give you a major addition to your armamentarium. So the tables are here, and we have Dr. Gorbis and Dr. Doan here, including myself, to just try to practice some of these techniques, and we'll just kind of roam around, and if you have any questions, feel free to ask. Anybody have any general questions right now? Or? Okay, thanks.